I want to welcome everyone to the ICOS Nurses Working Group meeting. We are so thankful for you to join us today. My name is Steve Caselli. I'm the Executive Director of ICOS, and we're thrilled to see this network of cardio-oncology nurses and related professionals beginning to develop. Before we begin, I just want to say a word of thanks to AstraZeneca for their generous support of this event today. We're very appreciative of our growing partnership with them, and we want to welcome some of their staff as they join us today. This initiative, the Nursing Working Group, really came about in conversations that I had with Carrie Skirka, who's a nurse navigator at Franciscan Health Alliance in Indianapolis, Indiana. And it was her passionate concern to see more resources brought to bear for cardio-oncology nurses that really led to the formation of this group. And our desire is that this group will become a network within our broader organization that will address both the educational and the practical needs of you all who are on the front lines of patient care. I know that many of you are either starting clinics or new to the field, and so we really want to create an environment where you have the support and resources that you need. And to that end, we are planning to host quarterly events throughout 2021, beginning February 18th. We'll obviously send out information with details about these events going forward. If you're not yet a member of ICOS, we have very reasonable fees for healthcare professionals, just $75 a year. And if you're a member, you can then be sure you're on our distribution list for information. If you want to learn more about that, go to ic-os.org. Well, as I mentioned, the birth of this group really came about through discussions with Carrie Skirka, and those of you who know her know that she is just passionate about this discipline, and she works tirelessly caring for her own patient load, but then also for promoting and providing resources for others in the field. So I want to welcome Carrie, and she's going to then introduce our speaker after some comments. Thanks, Carrie, for all your work.
Thank you so much, Steve, for that nice introduction. And I just want to thank the International Cardio-Oncology Society for letting us have this platform and this vehicle to reach out to one another. And we have a lot of opportunities. So I'm not going to go on very much more, but I will say that if you get an opportunity to join the ICOS, the webinars that they have weekly, the information is so good. And if you can't be there for the webinar, the great piece about it is that you can go back to the website and look at that information later. There's tons of information. It's a good place to rate, and I recommend them highly. So trying to bring education piece to other cardio-oncology nurses. I have the pleasure today of presenting a colleague of mine that I have had the pleasure of working with for a couple of years. And he is a part of our cardio-oncology team at Franciscan Health. And he is a professor at Butler University. And we were just blessed when they lent him as a clinical pharmacist to our cancer center. And so he does a great job of sharing educational information. He teaches me daily. And so today, I just want to thank you so much and hope that you will enjoy this presentation that Dave is going to be sharing with us. Cancer therapies in 2020, the new trends and emerging areas of focus. Thank you so much. Dave.
Yes, thank you, Carrie. Just want to make sure that the slides are showing up okay on the screen.
They are, Dave.
Excellent. Okay. Well, thank you for having me. As Carrie said, my name is Dave Reeves, and I am an associate professor at Butler University and clinical pharmacy specialist at Franciscan Health here in Indianapolis. And today I want to talk about some new cancer therapies, some trends that have been occurring for a while. Really, cancer treatment has undergone a significant change over the past 2 decades. New, more targeted therapies are being approved by the FDA, and they're actually quickly making their way into the standard of care for many or even most of malignancies that we see in the clinic. So today I'm going to talk about that and kind of where cancer is going through the next, hopefully the next decade or so. So as far as disclosure, I don't have any disclosures, any conflicts of interest to disclose. The objectives, today I'm going to discuss the shift in therapy from more of that cytotoxic chemotherapy type regimen to more of a targeted based therapy. Describe some of the benefits and risks of these therapies and kind of the challenges in managing these patients. And then finally finish up focusing on an older drug that has garnered increased attention at my institution due to a cardiac adverse effect, and that's fluorouracil. So the transition from cytotoxic drugs to targeted therapies has really been underway for quite some time, as far back as the late 1990s, early 2000s. We've really seen this shift from the cytotoxic drugs to the targeted therapies. This graph here shows the number of FDA drug approvals based on the type of drug. The green line represents the cytotoxic drugs, and the red line represents the targeted drugs. You can see right around this late 1990s, early 2000s that the shift really occurred in that these targeted therapies really took off to where in 2014 there were multiple 9 drugs approved that were targeted therapies, whereas 0 chemotherapy drugs were approved. We still see a chemotherapy drug approved every once in a while, but really where the focus is on these targeted therapies. And when we look at whether these trends are going to continue, this here shows the late phase oncology pipeline molecules. This ended in 2016 as far as the data collection goes. And the yellow is the cytotoxic chemotherapies. The blue are the targeted biologics like the monoclonal antibodies. And the darker blue are the targeted small molecule inhibitors like your tyrosine kinase inhibitors, all those drugs that end in NIB, NIB. You can see that really this trend looks like it's going to continue as far as targeted therapies go and targeted biologics. They're really taking over the landscape in the clinical trials, and it looks to be a sustained effort that will hopefully lead to much improvement in outcomes for our patients. Speaking of those improved outcomes in the patients, this here shows the number of deaths that have been averted. You can see the blue is the actual death rates in both men and women over from 1975 up to 2017, and the red line is what would be predicted if nothing were to be done. You've heard probably more than you wanted to over the last 7 or 8 months about flattening the curve. Well, you can see here in oncology where we really are flattening the curve. In men, it's estimated that we have over time decreased or averted upwards of 2 million deaths, and in women, we've averted upwards of 1 million deaths. So that's really good news for our patients, and it all has to do with all of these advances that we're making in therapy, largely in utilizing the targeted therapies. When we look at our peer nations, the United States is doing pretty good. We actually have one of the lowest mortality rates amongst our peers. And you can see that in all of our peer nations, the mortality rates are really declining over time. So this is something that we really like to see. You know, all of these therapies that we're coming out with, they may have some difficulties with utilizing them, but we are making progress in decreasing the mortality due to cancer. So to start talking about some of these therapies, first we need to define what targeted therapy is. Targeted therapy is any therapy that interferes with a cancer cell's proliferation by blocking aberrant intracellular signaling pathways that govern cell responses, movement, and division. Cancers have multiple mutations, oncogenes, and the likes that can cause cell signaling that promotes cell growth and division. So therapies that target these pathways, they can induce apoptosis. Some of them do stimulate the immune system to destroy cancer cells. And generally, there's two types of therapies. There's a small molecule targeted drugs that are usually orally administered. These are your tyrosine kinase inhibitors, as well as some other small molecule drugs. And then our monoclonal antibodies are the other class. So if you look at this picture on the side, this here is the cell surface. This would be a cell surface receptor with the extracellular side of the surface and the intracellular side of the surface. Under normal circumstances, a ligand binds to this receptor, causes then the receptor to be passed along to the nucleus to have some type of effect. In cancer's sake, it would be proliferation. So you get some mutations in these different receptors and different kinases that are passing that signal along that can lead to increased growth, decreased apoptosis, and basically provide an environment that cancer can grow in. So we have our monoclonal antibodies that can either bind to the outside here of the cell surface receptor to stop the interaction between whatever is going to bind to it and the cell surface receptor. We have monoclonal antibodies that bind to the different ligands that would bind to the receptors. And then we have those small molecule inhibitors that really work on these tyrosine kinases within the cell that stop those signalings from getting into the nucleus of the cell. In addition to that, we also have immunotherapies, and I have a couple examples of how these different immunotherapies are working. The first that I want to touch on are the checkpoint inhibitors, the immune checkpoint inhibitors. There's multiple that have been approved, pembrolizumab, nivolumab. If you've seen a cancer patient in the last year, you've probably seen a patient who's received one of these medications, probably pembrolizumab or nivolumab. The way that these work are that they are monoclonal antibodies that bind to cell surface receptors. So under normal circumstances, your immune system goes around looking for cells that don't belong and then gets rid of them. The tumor cells obviously don't belong, but they have developed ways where they can evade detection by the immune system. In general, they can express these different receptors on their cell that then tricks the T cells into believing that the cancer cells should remain and not be destroyed. So it's kind of like a secret handshake between your immune system and the different cells in your body. Is what they've developed are monoclonal antibodies, however, that can bind to these different receptors and block that secret handshake so that the T cell can then recognize the tumor cell as being foreign and then go after it and destroy it. We also have other monoclonal antibodies that can actually bind to the cell surface receptors and then act as kind of a flag to the immune system to say, hey, I'm foreign and I need to be destroyed. So then it kind of brings in those immune cells to target those cancer cells. And another interesting one is blinatumomab. This is a bispecific T-cell engager. This has two receptors basically that are put back to back. One receptor is for the tumor cell and the other receptor is for the T cell. So when these bind to the two cells, it basically brings them in close proximity, which then causes the T cell to go after the tumor cell. So it's kind of like a matchmaker type mechanism. So we have multiple mechanisms that take advantage of the immune system. The most popular, though, that is in use right now probably is the checkpoint inhibitor mechanism. And that's because it has shown to have many, many benefits in patients. This here shows just the benefits that have been seen in metastatic melanoma. Now, not all malignancies are going to show this type of impact, but this is one where these immunotherapies have made a very large impact. Prior to immunotherapies, The treatment of metastatic melanoma was very difficult. It did not like to respond to traditional chemotherapies, and in general, patients did not survive for very long with this diagnosis. However, if you look at the 5-year progression-free survival and then overall survival for patients, there are 2 different trials here. This one is the trial using pembrolizumab in patients with advanced melanoma. And this study on the other side is the patients receiving either nivolumab plus ipilimumab combination, or ipilimumab alone, or nivolumab alone. And you can see that in patients who received the pembrolizumab, overall survival out at 5 years is around 40%. So these patients are having very long-term responses. Progression-free survival, that would be the number of patients who have not had any increase in their cancer after starting therapy, at 5 years is somewhere around 30%. So that's a huge benefit for that 30% of patients where at 5 years they're not having any growth in their cancer. You can see here the Ipi-Nivo and Nivo and Ipi arms of this trial. The overall survival at around 5 years is anywhere between 25 and 50% depending on the therapy that they received. And again, progression-free survival is upwards of 36%. So these patients are, living a long time on these medications and gaining a lot of benefit. This is just one example. There's multiple malignancies where these have been used, but this is one where it's a very, very stark improvement on prior therapies that were available. Because of these improvements, we are using these drugs in more and more malignancies. This here shows the number of active trials in 2017 and then in 2019 for the different targeted therapy or immunotherapies, the checkpoint inhibitors that are either approved or in development. Pembrolizumab is the drug probably with the most approvals, and again, most therapy or trials as far as 2019 goes. Pembrolizumab currently has FDA approvals in 15 specific cancers. If you've ever looked at the prescribing information, the package insert for pembrolizumab, it is almost 100 pages long because of all of the data that they include for all of those different indications. It's pretty phenomenal how quickly it's moved into therapy for multiple different malignancies. But you can see that a lot of these drugs have multiple clinical trials still underway, so we're likely going to have it continuing to have expanded use in the future. Despite the benefits, there are multiple different toxicities that you can see with these drugs. Not only do they block that secret handshake between the immune system and different cells in the body with the tumors, but also with our normal cells. So basically anything that can be, any cell in the body could be attacked by the immune system. So you see a lot of these different kind of more autoimmune looking adverse effects. So you can see rashes, you can see some colitis or diarrhea that looks kind of like a Crohn's, hepatitis, pancreatitis. You can see different endocrine issues, thyroiditis, which leads to hypothyroidism, or other pituitary issues. You can see a ton of different inflammatory adverse effects with these medications. As far as cardiac adverse effects go, the main things that we're going to see are things like pericarditis and myocarditis, which can be very, very difficult to treat in these patients. As far as the treatment goes, this here shows the NCCN guideline recommendations for one of the adverse effects. This is just to kind of give you an idea of how these patients are managed. For mild disease, for mild toxicities, generally you're going to consider holding the therapy. This would be for diarrhea, giving them antidiarrheals. For more moderate disease, that's when we're considering maybe adding in the prednisolone. And then for severe disease, that's when we're thinking about more of these targeted anti-inflammatory drugs like infliximab or vedolizumab. For something like myocarditis, again, you're probably going to have a shorter time to putting the steroids on because of the seriousness of the adverse effect. And then if patients don't respond, then you're looking at utilizing agents such as antithymocyte globulin, infliximab, IVIG, mycophenolate, all of those more potent immune suppressants to try to get that inflammatory response under control. Moving on to the oral targeted therapies. Like I said earlier, these work on the intracellular side of the cells. They are blocking that signaling from going from the cell surface receptor down to the nucleus to have those different effects. There are multiple different targets, things like ALK, BCR-ABL, BRAF, or BRAF. All of those are different targets, and it's continually evolving. They're adding more and more targets, it seems like every single day, but they all have their own set of complications and issues associated with them. Like the immunotherapies, these have really revolutionized treatment of multiple malignancies. There's over 50 of these medications that are FDA approved, and it seems like we get a new one pretty much every month, if not every week, during some times of the year. It allows some patients to actually avoid chemotherapy. So we're able to give these oral drugs, and patients can actually avoid those cytotoxic chemotherapy drugs, which allows us to treat the patients at home, which is very comforting to the patients, I know, is that they don't have to spend days sitting in our infusion center. Even though we treat them very well, they would rather be at home. This excuse me, this here on the slide shows an example of kind of how these medications have really taken over some different treatments of malignancies. So this shows advanced renal cell carcinoma. Prior to these drugs being approved, which they started using targeted therapy in advanced renal cell carcinoma probably 2005, 2006. And since then, they've really taken over. And you can see that there aren't any chemotherapy regimens actually recommended in the treatment of renal cell carcinoma. It's all targeted therapy. So things like sunitinib, pazopanib, even using some of our immunotherapies, ipilimumab, nivolumab, we're really taking the chemotherapy out of some of these medications, or out of these regimens for some of these malignancies. One of the biggest success stories for these targeted therapies is in CML. This is one of the first tyrosine kinase inhibitors to be approved by the FDA, and it really showed a significant impact. This here shows our old treatment for CML, interferon and low-dose cytarabine for newly diagnosed chronic phase CML patients. This is the progression-free survival at 2 years. Combination therapy, you see, was around 70% were progression-free. Typically, patients with CML, they would respond for a while to the low-dose cytarabine and interferon, but then they would ultimately progress and would require a bone marrow transplant. The imatinib, however, you can see at 95% progression-free survival just about at 24 months. So this is a huge improvement. There's a lot of enthusiasm about it. It was approved by the FDA. All the patients were switched over to this medication, but there was still some concern about how these patients would do and how long or how durable these responses would be. When you look at the 10-year survival with the imatinib, 10-year survival is 83.3%. Interferon is at 78.8%. This is a huge deal that 83% of these patients are alive at 10 years. It looks like the interferon and cytarabine also did well, but if you think about what you would want to do if you're on the interferon arm, you'd probably want to jump over the imatinib arm, and in fact, that's what most patients did. Once they progressed on the interferon and cytarabine, they jumped onto the imatinib arm, so that's why you see even a benefit in that arm. where almost 80% of the patients are alive at 10 years. But again, this has really revolutionized the treatment of CML. There's now 5 of these that are approved for CML, and really prior to these, CML was one of the most transplanted disease, and now it is not even close. We rarely ever see a CML patient needing a bone marrow transplant, not like we did in the past. Another interesting thing that these targeted therapies have led to is the rise of tumor agnostic therapies. So if you think about different regimens that are used for cancer, they come up with a regimen, they try it in a specific cancer, let's say breast cancer. You can think of like HER2 positive breast cancer using trastuzumab, doxorubicin, and cyclophosphamide as a common regimen with a taxane. And they try it in the specific regimen, and it gets approved for that cancer, and that is the treatment for that cancer. However, now that we have these targeted therapies and we have ways to find these different mutations in the cancer, we're less interested in the tissue that it came from and more interested in the different gene mutation or biomarker that is being targeted. So tumor agnostic therapy uses the same drug to treat all cancer types that have whatever genetic mutation or biomarker that is targeted by the drug. There are currently 3 drugs that have tumor agnostic indications. The first is pembrolizumab, which can be used for microsatellite instability high tumors or have those with a high tumor mutation burden. Those tumors, they've shown that they respond really well to the immunotherapies, and we can use them despite any tissue that it comes from. We can use it as long as it has that signature. And then we have larotrectinib and entrectinib, which are 2 oral drugs, tyrosine kinase inhibitors that are targeted at the NTRK gene fusion and can be used in any solid tumor that has that particular gene fusion. So it's really interesting that we can now worry less about where the tumor is coming from and more about what's actually going on within the cell. Despite the advantages of oral therapies, there are multiple downsides to them. The first being adherence. We're not having the patients come in and sit in front of us while they're getting an infusion, so that we know that they're getting the drug. There are a lot of delays in starting therapy. A lot of these come from different specialty pharmacies, and they require a lot of insurance approvals and patient assistance. So there are some delays in starting therapy, sometimes upwards of a week or 2 weeks, or sometimes even longer. There's a lot of drug-drug interactions, which we'll talk about. Monitoring is a little more difficult because these patients are getting this in the outpatient setting. So it's more difficult to really assess tolerability and supportive care on an ongoing basis. And as you would imagine, these medications are all extremely expensive. So when we look at adherence, this is a study looking at patients who were in a Medicare Part D database who had CML during their first 180 days of treatment with one of those tyrosine kinase inhibitors for CML. Adherence was defined as receiving or taking greater than or equal to 80% of the doses or days that they required a dose. And they showed that over time you have a decrease in adherence, and you have a decrease in response among those who are non-adherent. So you see here overall, if there is non-adherence, the response goes from significantly down, and there was a lot of non-adherence at each time point that they looked at. I'm sorry, this isn't response. This is just specifically adherence. The response is another study where they showed that there was a decreased response in patients who were non-adherent, but only 70% of the patients are getting all of the drug that they should be getting, which is difficult when we know that the response is tied to them taking the medication. Looking at drug interactions, a lot of these medications are metabolized by the liver. Most of the medications are metabolized by the liver. These oral ones, the tyrosine kinase inhibitors, a lot of them have the CYP3A4 drug interaction. So you can see here some significant medications like our anti-seizure medications, different things like some of our blood pressure medications can also interact via these CYP3A4. Our antiarrhythmics definitely can interact through the cytochrome P450 pathway. You can see a lot of these tyrosine kinase inhibitors are metabolized by that enzyme. So we really need to pay attention to the medications that these patients are being started on so that we don't have an increase in drug levels, because there can be a significant increase in adverse effects that can be really, really problematic for the patients and lead to, it has led to hospitalization due to significant issues with the adverse effects. In addition to the prescription medications, we also have to worry about things that patients can get over the counter that, say they have a little bit of heartburn. They can go and get a proton pump inhibitor like a Pepcid, or not Pepcid, a Protonix, or something like a Pepcid, an H2RA, or even an antacid. They can all decrease our patient's exposure to these medications. You can see that some of them you should avoid these different medications. So it's important that the patients are being informed and educated on these different adverse effects so that they're not decreasing their exposure and decreasing their potential benefit. A lot of our cardiac patients are going to be, or a lot of patients who are seeing a cardiologist are going to be receiving drugs like acalabrutinib, which can increase your risk for AFib. So patients, who have AFib going there, maybe have a little bit of heartburn, we wouldn't want to recommend them taking any of these, like a proton pump inhibitor, potentially maybe an antacid or H2RA, but definitely not a proton pump inhibitor. So it's just something to keep in mind whenever you see a patient who is on one of these targeted therapies, that we need to look into, make sure that we're not causing a drug interaction when we are recommending different therapies. Food interactions can also occur. Any change in the gastric pH can decrease the absorption and dissolution of different medications, as well as high-fat meals can decrease emptying rates, increase the dissolution of fat-soluble drugs. You also have chelation issues with polyvalent metal ions, so things that maybe are higher in calcium, like milk or yogurt or something like that, can potentially chelate some medications. And then we also have interactions via the different enzymes like the cytochrome P450 and P-glycoprotein due to interactions with grapefruit, which can also occur with pomegranate and starfruit also to a lesser extent. Probably one of the hardest things to keep our eye on and wrap our minds around are the drug-herb interactions. And that's because patients often take these without notifying us that they're actually on them. This here looks at 149 patients, 56.4 reported using concurrent herbal supplements, and among those 122 possible interactions were detected. This may overestimate the number of patients who are receiving herbal supplements because it was a Latin American study, so there is more herbal supplement use there, but nonetheless the message is the same, that a lot of these medications can interact with our drugs that we're giving them, particularly when we're giving them these oral drugs that have a lot of hepatic drug interactions. one of the most common questions that we get in the clinic is, what about CBD oil? Can I use CBD oil? And really, like any other herbal medication, it's difficult to know. But luckily with this, there is an FDA approved formulation available. It's used for seizure treatments and it's called Epidiolex. In the interaction studies that the FDA did, it was shown to inhibit CYP2CH, 2C9, and 2C19. And it also may inhibit or induce CYP1A2, 2B6, as well as inhibit UGT1A9 and 2B7, and also may inhibit a couple transporters, the BCRP transporter and the BSEP. So there are a lot of different potential drug interactions that can occur with the CBD oil. So it's important that we are checking to make sure that we're not giving drugs that can potentially interact in this way. And another study looking at CBD oils that patients were receiving, or they actually went and looked, it was like a news article. They went and did an investigation and looked at different products that are available on the market. And they showed that up to 70% of the products tested had heavy metals, lead, arsenic, pesticides, mold, and other impurities. Now, even if it doesn't interact with the patient's medication, we don't know how the arsenic or pesticides are really going to interact with the medication. So all in all, our stance is that patients should not use CBD oil if possible, just because there's so much unknown about it. And if they're going to, we ask that they not buy it at a gas station and make sure that they're trying to get it from a reputable establishment. When we think about tolerability of these oral therapies, you got to think about it differently from the IV chemotherapies. So you have your IV chemotherapies that the patients receive. They get a dose or maybe over a couple days at most, and then they have 3-4 weeks off where they're able to recover from the different side effects. They may be hit hard that first week or two, but then they get usually a week or two of reprieve where they feel decent. When we think about these targeted therapies, however, these patients are on them constantly. And while we might not have a severe adverse effect like a severe nausea or a severe neuropathy that then goes away, we do have these mild nagging adverse effects that can sometimes become severe. So if you have maybe a nausea that's just like this mild nausea that you have every single day, no matter what, it can be problematic for the patients and lead to decreased quality of life. So we need to make sure that these patients have those issues addressed so that they can enjoy as much of their life as they can. In addition to the tolerability issues and different toxicities that we see, as far as, you see a lot of diarrhea, mouth sores, and we also have to worry about financial toxicity, which can be significant in with these patients, especially the fact that they are purchased in the outpatient setting with things like Medicare Part D and different prescription insurance plans. And those without prescription insurance plans are really at a loss. So this here shows Medicare Part D beneficiaries. This is the cost and the year. This would be per patient per month. And the blue are the out-of-pocket costs, and the yellow is the total cost. And you can see that these patients are having an out-of-pocket cost of anywhere between $800 to $1,000. And a total cost of upwards of $8,000. And if you notice, this goes through 2012, this doesn't go through 2020. This has significantly increased. Sometimes we have patients on medications that are costing upwards of $10,000 a month or even more. So if you think about a copay on something like that or not having insurance, it can be significant for these patients. And if you think about the Medicare Part D, where you have the donut hole and copays and everything, it can be very, very difficult. Lucky for the patients, there is a decent amount of support for them. We have the different drug company programs that can offer either copay assistance or access to free medication for patients who don't have insurance. So there are ways that we can get it, but it can lead to some delays. And some patients who have insurance who don't meet the requirements for these different programs do have a significant out-of-pocket cost for these medications. When we think about the cardiac impact of these oral targeted therapies, you can see that almost a large majority of these have QT prolongation that we have to watch for. These all are going to impact QT at a varying extent. Some require very, very frequent monitoring. Others require monitoring only in patients who have other risk factors for QT prolongation, but it is a significant concern. Another issue is hypertension. A lot of the medications, particularly those that target the vascular endothelial growth factor, are going to be causing a lot of hypertension that can sometimes be refractory and difficult to treat. So they're likely to show up in a cardiac clinic near you if they're receiving one of these medications. And then heart failure can also occur. When we think about heart failure, you think about things like the doxorubicin, the trastuzumab, those traditional things that we would attribute to heart failure. However, a lot of these oral tyrosine kinase inhibitors can also cause decreases in the ejection fraction and left ventricular hypertrophy. So that is something that we do have to monitor. Some of these also, require frequent monitoring like we do with the anthracyclines. It's just something to keep your eye out for because it does occur and we do need to monitor for it. Here at Franciscan, I know that you all are very aware of what cardio-oncology is, but we are very happy to have a cardio-oncology team at Franciscan Health. This here shows one of our cardio-oncologists, Dr. Rao, with Carrie Skirka and Holly Page. And they are a great resource for us in the oncology clinic and really, really help to manage all of these cardiac adverse effects in our patients. Now I'd like to kind of turn my talk to discuss 5-fluorouracil-induced vasospasm. We've had a lot of renewed interest in this medication due to this adverse effect, particularly with the increased involvement of our cardio-oncology team in our clinic. So I want to just kind of discuss some of our experience with this. It was brought to our attention after we had a medication event. It was a 68-year-old male with colon cancer who was receiving a 46-hour infusion of fluorouracil in the outpatient setting. They presented to the emergency department complaining of chest pain. The patient had no prior cardiac history. The nurse who was seeing the patient documented that they had chemo that was being administered via a CAD pump. They had an EKG that showed hyperacute T waves and a diffuse ST elevation with new onset atrial fibrillation and a rapid ventricular response. The patient was immediately brought to the cath lab that showed moderate LAD disease. No intervention was required, and they documented that the cause of chest pain was likely coronary artery vasospasm. The interesting part was that our 5FU infusion went unnoticed and continued in the emergency department, the cath lab, and throughout the patient's transition to the CCU. In the morning, the patient called actually the oncology clinic to notify them of his admission and to obtain guidance regarding what he was to do with his CAD pump that was finishing, and he had an appointment that day to actually have it removed. The clinic nurse promptly went to the CCU and discontinued the pump. So 5FU-induced vasospasm is something that we worry about with both fluorouracil as well as its oral prodrug capecitabine. They are used for multiple malignancies, particularly those of the gastrointestinal tract and head and neck. It's associated with coronary vasospasm, and the reported incidence of chest pain has been upwards of 15%. Sometimes it's reported very infrequently at 0.5%, but upwards of 15% have reported it in different trials. It's estimated that the vasospasm could occur in up to 68% of patients receiving 5-FU. The immediate management of 5-FU-induced vasospasm involves discontinuation of that 5-FU infusion, which is something that we failed to do here at Franciscan when we had a patient, and why we had all of this increased attention to this adverse effect. Some patients have been able to have a rechallenge, and generally they require co-administration of vasodilating therapies. And generally there's limited data available to describe the presentation, acute management, and outcomes of patients experiencing 5-FU-induced coronary vasospasm. For that reason, we decided to take a look at our experiences here at Franciscan Health, and we wanted to take a look at our patients and describe what we were seeing as far as chest pain and coronary vasospasm. We are a community oncology practice, and we looked at our patients between January of 2017 and December of 2019. When we looked at the data, we had 437 patients receiving fluorouracil either alone or in combination with other agents. And out of those, 15 actually had coronary vasospasm. So 3.4% of our population had chest pain or coronary vasospasm. The median time to onset was during the first cycle. Some people did have it occur during the later cycles, up to cycle 4. 9 of the patients presented to the emergency department, 6 describing chest pain during their office visit. So the majority did come to the emergency room, but there were a couple that just described chest pain during their infusion when they came to the next oncology office visit. 3 of the 9 patients presenting to the emergency department had an ST elevation that prompted emergent cardiac catheterizations. 2 patients had no coronary disease, and 1 had 50% coronary lesion that was treated medically. All 3 of the STEMI presentation patients did not have their 5-FU continuous infusion pumps discontinued until after their catheterization was done. And all patients experiencing the chest pain were referred to Cardio-Oncology service for further management. You can see here the regimens that the patients received. The majority we're receiving are standard therapies for colon cancer like FOLFOX, FOLFIRI, and then FOLFIRINOX can be used depending on how it's given for either pancreatic cancer or colon cancer. And then there were some that had a 96-hour continuous infusion of just the fluorouracil with radiation, which is largely seen more in our head and neck and anal cancers. When we look at how the patients were managed, you can see here would be our 3 ST elevation patients. Of the 9 that came to the emergency department, 6 presented in the office and described their chest pain to the oncologist who was seeing them. Of these 6 patients, 6 were rechallenged and 5 actually were able to complete their therapy. Of the patients who went to the emergency room, of those who had a negative cardiac workup, all in all, 4 of them were able to have their therapy completed via a rechallenge. And when we look at those patients with ST elevation, you can see we did rechallenge 2 of them, and they were both discontinued due to cardiac issues, one being a cardiac arrest. So there are patients who can be rechallenged. Some do advocate that if the catheterization demonstrates a blockage, that those patients are probably at a have a better chance of tolerating therapy because you can fix that blockage. And then if there's future vasospasm, it's not going to cause the symptoms and the ST elevation. Whereas if the catheterization was clean, then they recommend potentially not rechallenging due to the fact that all of the symptomology was due specifically to the drug-induced coronary vasospasm. So we have rechallenged some patients, and some patients have tolerated it. The patients that we did rechallenge, the majority of them are receiving vasodilating therapies like calcium channel blockers, plus a nitrate, and almost 60% of them, and a calcium channel monotherapy, and almost 30%, and nitrates, and a little over 10%. Based on our patients and this analysis that we did, and us noticing that 3 of our patients had a cardiac cath despite having their fluorouracil continuing to run, we did see that there were many opportunities available for improvement. Obviously, appropriate management relies on prompt identification of the fluorouracil as a potential cause of the vasospasm, and we wanted to increase awareness among our cardiac, emergency care, and oncology providers, and ensure easy identification of patients receiving the 5-FU infusions within the emergency care setting. So the things that we did at Franciscan were to implement a large bright blue tag on our continuous infusion devices with instructions for our emergency care providers, specifically that if the patient presents to the emergency room, to stop the pump, and instructions on how to stop the pump. We also implemented a wallet card for each patient just so that they had information about their oncology treatment and regimen. We have implemented a warning sticker over the infusion port so that when they are looking at the patient and seeing he has that infusion going, it has instructions on what to do right at the port. So when they're assessing the patient in the emergency room, listening to their chest sounds and whatnot, they can actually get a warning from that sticker on the infusion port. And we also provided a lot of education to our emergency department, our cath lab, and cardiac care unit, just to keep an eye out for this, to ensure that our patients are being appropriately managed. So in conclusion, immunotherapy and targeted therapy are here to stay and have led to significant benefits in patients, and hopefully will continue to lead to even more significant benefits. But despite the improvements in efficacy, the new therapies do come with challenges such as unique side effects that require monitoring, including frequent cardiac monitoring by our Franciscan Health Cardio-Oncology program here at Franciscan Health. And the last thing I want to point out is that old drugs can still surprise us. With more attention on cardio-oncology and more attention on 5-FU-induced vasospasm, the incidence appears to be higher than expected. So I thank you for attending and listening to me today. This is the C&E information.
Thank you so much, Dave. I want to make sure all of you, that was just a great presentation. And we have a few minutes if you had any questions. I'm sure that Steve can help us with that. And if you want, you can get your C&E by putting your phone over this square. And Steve, will this be in our the saved webinars on ICOS?
It will, yes. It'll be available on our website.
Did we have any questions? That was just a great presentation.
There are a couple questions. Kelly Garcia, do you want to jump in? Okay, Kelly had asked, when you did the 5-FU analysis, did you look at patients who were receiving Avastin as well?
No, it was just for 5-FU. We did include capecitabine in that look. So no, it was Avastin was not included in that.
Okay.
Yeah, and interestingly, I don't think any of the patients were receiving Avastin in combination with the 5-FU.
I think that is correct, because we see that combination a lot, but that was, I do believe that that is true.
And Kimberly Ross, do you have a question?
Hi, yes. I was just curious, with the vasospasm with the fluorosil that was seen, did you see any type of age comorbidity correlation in any of those patients?
You know, we actually did look at that data, and I'm trying to think off the top of my head. We looked at their comorbidities, and you know what? I will just send that analysis. I have that analysis that I can send out to you specifically in a couple of PowerPoint slides, and I'll just give them to Steve so he can share that with you. But they
That
did,
sounds great.
they did tend to have more comorbidities.
All right, thank you so much.
You're welcome.
And Victoria Fenimore, you have a question?
Hi there. Yeah, so I have one question more about your role in the cardio-oncology program. In ours, we don't necessarily have a specific pharmacist that we work with. We do have oncology-based pharmacists in the cancer center, but our cardio-oncology program is in the Heart Institute. So I was just wondering about that.
Yeah, so my training is in oncology. I mean, I learned about these drugs in school as far as cardiac goes, and I did a residency and had some cardiac rotations and stuff. But the bulk of my training and my specialty residency was in oncology, and that's where I'm housed, is in our oncology clinic. However, part of what I do is I do cover the cardio-oncology clinic, and it's more to serve as a resource or reference for them, for our cardio-oncologists and nurse navigators regarding the cancer therapies, not as much the treatment of the cardiac adverse effects, but more as a reference for them from the oncology side. With everything being virtual, I've been more of a virtual reference, but when we were having our clinic over in our cardiology building, I would go over there and spend the afternoon with them to be able to serve as that reference for them.
Okay, thank you so much for your presentation.
No problem. And also, you know, our nurse navigators are actually embedded within our oncology clinic, so I work very closely with them. Their office is right down the hall, so it leads to a really nice collaborative environment.
Yeah, David's just, he's so important to what we do. And I think, you know, as we think about all of us coming from different aspects and delivery systems for our care for our patients, and how we might partner with other disciplines, looking at the pharmacist is such a great asset to our program. So I want to tell you, thank you so much, Dave, for your presentation today. It was extremely helpful for me, and I hope it was helpful for others. I want to thank ICOS once again for offering us this platform so that we might share. I want to thank all of you for joining us today. And Steve will be sending out to all of you that responded. And as we go to, we have a short survey. It's only a few questions as we are trying to plan for next year. We have set up 4 webinars, planning for the next one to be in February. I believe it was February the 18th, tentatively. But we're looking for further development of our network. So I want to thank you, Steve, so much for all that you've done to help us in this delivery of this program today, and turn it over to you for any last minute.
Yeah, just again, thank you all for joining us today. Thanks again to Dr. Reeves for this wonderful presentation. And if y'all have any feedback for us, obviously through the survey, that would be helpful, but also just personally, you can always email me. My email's on the ICOS website. So we really appreciate you being with us today, and look forward to having you join us again in the future. Thank you so much.
Indeed. Thank you, Dr. Reeves. That was great presentation. This is Janet in Orlando, and Carrie and Steve, thanks for spearheading this. I'm looking forward to some great webinars in 2021. This will be a great format. Thank you again.
Thank you,
Thank you
Janet.
all. Have a great day.
Have a great day. Be safe.
Stay well.